And I'm going to start the webinar in 3, 2, 1.
Hello, everyone. We're going to get started in just a minute. Give people just a couple of moments to sign on. So hi, everyone. Welcome to the webinar, Patient-Centered Dosing for Individuals with Metastatic Breast Cancer. I'm Christine Benjamin. I'm the Senior Director of Patient Services and Education at SHARE. Before the presentation begins, I would like to tell you just a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, metastatic breast, ovarian, and uterine cancer for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, you can always check out our website at sharecancersupport.org. So all participants will be muted. I keep getting this weird pop-up on my screen here. I'm not sure what's happening. Oh my goodness. I'm having a technical problem. Here we go, one sec. So all participants will be muted during the presentation. When Dr. Bardia and Anne finish presenting, we'll begin the Q&A. You're welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat function will be disabled during the webinar. When asking questions, remember that the presenters are unable to give specific medical advice, so please keep your questions general in nature. The webinar is being recorded and will be available on the SHARE website soon. So for some reason, this is not letting me scroll. Here we go. So let me introduce our speakers. Anne Loeser was diagnosed with early stage breast cancer at age 39 and with metastatic breast cancer 18 years thereafter. On both occasions, her symptoms were misdiagnosed, an experience that subsequently transformed her into a patient advocate, researcher, and author. Anne's continually updated book, The Insider's Guide to Metastatic Breast Cancer, has been described by Mark Burkard as a labor of love in which deep knowledge and years of experience are shared in an organized and accessible format. Every drug, every breast cancer subtype, every scan, every site of the disease, it's there. Anne is a member of the Metastatic Breast Cancer Alliance, Komen Greater New York City's Metastatic Advisory Committee, a research grant reviewer, and a project lead graduate. Her concerns about patients' treatment-related side effects motivated her to establish the Patient-Centered Dosing Initiative, a movement made possible through the concerted efforts of patient advocates and medical professionals that encourages collaborative decision-making about the optimal allowed treatment dose for each patient based on the patient's unique characteristics and circumstances. Anne is profoundly grateful to the numerous advocates and medical professionals whose efforts have enabled cancer dosing considerations to come to the attention of the FDA, ASCO, and other leading organizations. So please check out Anne's book. We were talking earlier about this book is on my desktop. It lives there, it stays there. It has so much great information. So let me introduce Dr. Bardia. He's a board-certified medical oncologist and attending physician at Massachusetts General Hospital Cancer Center and assistant professor of medicine at Harvard Medical School. As the director of Precision Oncology Program at the Mass General Hospital Center for Breast Cancer, Dr. Bardia has led the clinical development of the recently approved antibody-drug conjugate sacituzumab govitecan, and is working on an investigational oral estrogen receptor degrader for patients with metastatic breast cancer. Dr. Bardia is particularly interested in dosage adaptations to maximize quality of life for individual patients while maintaining treatment efficacy. He has received several research awards, the Outstanding Award for Research Excellence at the Mayo Clinic, Young Investigator Award from ASCO, and the Douglas Family Foundation Prize for Excellence in Oncology Research. Dr. Bardia is the editor of Precision Medicine Clinical Section of The Oncologist, co-leader of the Molecular and Precision Tumor Board at Mass General Hospital, an editorial board member of ASCO Molecular Oncology Tumor Board. Thank you so much, Anne, Dr. Bardia, for being here. I'll turn it over to you, Anne.
Thank you very much, Christine. I'm going to share my screen. Can you see my screen?
Yes.
Okay, thank you. So as Christine said, and thank you for that kind introduction, my name is Anne Loeser. I'm a metastatic breast cancer patient advocate, and I'd like to thank SHARE for inviting Dr. Aditya Bardia and myself to speak about patient-centered dosing for individuals with metastatic breast cancer, or MBC. In my presentation, we'll be discussing the following: the cancer drug dosage paradigm, phase 1 clinical trial dose escalation, why doses even matter to us, dosage-related studies, and then we'll discuss the Patient-Centered Dosing Initiative, or PCDI, which was founded by patient advocates. We'll discuss the PCDI's Patient and Medical Oncologist Survey results and find out what we as patients can do, and we'll have a look at what success looks like. The cancer drug dosage paradigm, or the premise by which drug dosage is identified and administered, can be summed up in 3 words: more is better. It comes down to this: the idea is to administer the highest dose with the greatest toxicity as frequently as possible. And that paradigm has been around for decades. Dose escalation methods used in today's phase 1 clinical trials were developed in the era of chemotherapy or cytotoxic drugs all the way back in the 1960s. It's been assumed until very recently that both efficacy and toxicity increase with increasing dose. And by toxicity, we're talking about the measurement of the dose needed of a particular substance to damage a living organism. Just about anything in sufficient quantity or concentration can be toxic, even water. Phase 1 clinical trials measure toxicity and not efficacy as the primary endpoint. The most commonly used dose escalation method in phase 1 clinical trials is called 3+3. This slide will lay out in words how that is done. And I guarantee you it will be confusing to you. And I also guarantee that the next slide, when we see it in action, will make everything clear. So this is how it works in a 3+3 dose escalation phase 1 trial to find the dose that will go forward. 3 patients are initially enrolled into a given dose group or cohort. If there are no dose-limiting toxicities, or DLTs, which are typically severe adverse events, grade 3 or 4, 3 more people are enrolled at the next higher dose. If even 1 person develops a DLT, 3 new people are enrolled at that same dose level. The development of DLTs in more than 1 of 6 patients in a specific group suggests that the maximum tolerated dose, or MTD, has been exceeded, so the next lower dose is considered the MTD. Confusing as mud, be made clear immediately. There we go. You'll see the arrow that points up in green, and that signifies increasing dosage. And now we're going to begin our phase 1 clinical trial. We enroll 3 patients at the lowest dose, and that dose has been extrapolated from preclinical models, and those are usually mice, and then the dose is extrapolated for use in humans. So we start slow, no one has a DLT. We go up a level of dosage, but in this case, 1 person, the one in the middle, has a DLT. So we cannot go up a dose, we have to go sideways. We enroll 3 more people at that dose. They do well. So we could go up a level, and they do well. We go up another level, but in this case, 2 people develop a DLT. So we have to go down a level and enroll 3 more people at that 3rd tier. Another 3 people are enrolled just to be sure at that same tier. Everyone does well, and that becomes the maximum tolerated dose, or MTD, which is sometimes referred to as the recommended phase 2 dose, because it's used going forward in the clinical trials. If the drug is approved and nothing has changed, when administered in the clinic, when you're in front of your doctor getting this drug, it's referred to as the recommended starting dose, or RSD, or standard dose. And this is very typical of the volume of people enrolled in a phase 1 3+3 dose escalation trial. As you can imagine, there are limitations of 3+3 dose escalation. It's based on the premise that the higher the toxicity, the greater the efficacy. It has small fixed group sizes. It doesn't take into account long-term treatment side effects. It ignores levels of drug efficacy associated with lower doses. Those 2 lower tiers, we'll never find out how efficacious they were. It doesn't have relevance completely for targeted therapies, which are more modern therapies, where DLTs may not occur at doses that are even above the optimal biological dose. And by optimal biological dose, we're referring to the lowest safe dose associated with biological efficacy. And Dr. Bardia will speak more about this. Patients' responses in the real world differ from those of clinical trial participants, and this could be a huge issue or drawback. In clinical trials, to be accepted, the subjects are subjected to very rigid inclusion and exclusion criteria. But in the real world, that doesn't happen. So patients in the real world may have substantially different personal attributes than clinical trial participants. Well, we've talked about the drug dosage paradigm, but how true is it? How well does it hold up? In the 1990s, more than 41,000 breast cancer patients underwent a procedure called high-dose chemotherapy plus autologous bone marrow or stem cell transplant, with the hope that these really high toxic doses would cure them of their disease. In the beginning of the century, in the year 2000, the New England Journal of Medicine reported the results of a major randomized trial of this for patients with MBC and determined that there was no survival advantage compared with standard dose chemotherapy given at that time. So this is where the paradigm of the higher the dose, the higher the toxicity, the greater the efficacy began to crumble. Why, to us as participants in this webinar, should dosage levels even matter? Well, patients with MBC are treatable, but we're not curable, and most of us will remain on treatment for the rest of our lives. As a result of toxicity-related side effects, patients with MBC have been known to visit the ER or hospital, be unable to receive our treatment on schedule, and in many cases experience a degraded quality of life. Although we do need more data, recent evidence suggests that allowed lower doses of some MBC therapies can be as effective as the recommended starting dose and precipitate fewer or less severe side effects. Furthermore, lower doses may enable some patients to remain on a working therapy for a longer period of time. So rather than drop the therapy because of toxicities, they'll drop it when it no longer works for them. We alluded to allowed drug doses. what really are they? If you open a package insert of a drug for MBC, you'll see a recommended starting dose. In some cases, if there is an adverse event or side effects, there are lower doses that are allowed to be given in those circumstances. The number of possible dose reductions can be anywhere from 0 if the drug is only available in 1 dose, all the way down to 3 dose reductions. We'll see that in a minute. The percent of the original dose can go as low as 25% of the RSD. Here's an example of a CDK4/6 inhibitor called Verzenio when taken as monotherapy. Normally, patients are started on the recommended starting dose of 200 milligrams twice daily. It's also called the standard dose or maximum tolerated dose. If the patient is struggling on that dose, having side effects, they're allowed a dose reduction down to 150 milligrams twice a day. If they're still struggling, they could go down to 100 milligrams twice a day. And if they're still having issues, they could be allowed a third dose reduction of 50 milligrams twice a day, which, as you could see, is only 25% of the 200 milligram twice daily dose. So that implies that there is still sufficient power or efficacy in that low dose as to be prescribed in specific circumstances. But truly, I wish that we had efficacy-related data about every single MBC drug dose, but we don't. But here are 3 dose-related studies that I'll briefly share with you. One is of Verzenio, which we just saw. One is of Ibrance, another CDK4/6 inhibitor. And the one on the bottom is Xeloda or capecitabine, which is an oral chemotherapy drug. In all 3 cases, a lower dose was at least as effective as a standard dose, and it precipitated fewer or less severe side effects. And I'm just going to hone in on the second and third arrows under Verzenio. In this particular phase 2 study, which had 2 arms that gave it as monotherapy, the overall survival on the first allowed lower dose of 150 milligram twice daily was 20.8 months versus 17 months on the recommended starting dose of 200 mg. Now, I will caution all of us, a lower dose is not always the better dose. There are many things that need to be taken into account. And I did find a case of a drug called Piqray, where the absolute lowest dose was not quite as effective in terms of PFS as the recommended starting dose. We definitely need more information about efficacy, and the Patient-Centered Dosing Initiative is striving to get that. And we'll talk more about that later. The PCDI was formed in 2019 by patient advocates with a mission to enhance quality of life while maintaining therapeutic effectiveness by enabling patients with MBC and their doctors to identify the optimal allowed dose of treatment based on each patient's unique physical, circumstantial, and psychological factors. That's quite a mouthful, but really what it comes down to is a brand new paradigm. So instead of prescribing the recommended starting dose at the beginning of each new treatment and later reducing the dose when the patient has a side effect, we are encouraging doctors and patients to discuss the patient's attributes and personalize the starting dose for them in clinical practice. Again, provided that the dose comes in, that the drug comes in more than 1 dosage. What are these patient attributes? We call them patient-centered dosing criteria, and we've identified 9 of them. One is the person's goals and wishes. So if your daughter is getting married in 2 months, chances are you want to feel really well on her wedding day, and you don't want to have uncontrollable diarrhea. So that's something to communicate and discuss. The patient's performance status, other illnesses, their age, their health situation. What is their history of side effects from other drugs? Some patients tend to be much more sensitive to drugs than others. What are the current and historical blood counts? Is the disease aggressive or is it indolent? Is there organ dysfunction or CNS metastasis? What is the patient's body mass index? I'll just go off on one of my famous tangents for 1 second, or a little longer than that. The average BMI of an American adult female is 29.6. So we can surmise that the patients in phase 1 clinical trials who participate in a phase 1 trial such as that we saw are around that body mass index, somewhere within a few points. But in the real world, there are people with much higher BMIs and much lower BMIs. So there is a big degree of variance with respect to tolerability, or there could be, with regard to BMI. What is the patient's financial situation? If they need medications or a referral for side effect mitigation, can they afford that? And finally, and really importantly, what is their availability of at-home care? So if the patient is wheelchair bound and there's no one to help them, is it in that patient's best interest to give them the highest dose of a drug that will precipitate really acute nausea? These are all things we're taking into account, and I'd like to take a moment to introduce you to our 5 patient advocate team members. Many of these names and faces are familiar to you, I'm sure. Martha Carlson, Janice Cowden, Julia Mayos, Sheila McGlown, and myself, the founder. We're very blessed to have 5 amazing medical oncologists on our advisory board. Dr. Aditya Bardia, who you'll hear from in a few minutes, Drs. Mark Burkhardt, Kevin Kowinski, Mari Mlesberg, and Hope Rugo. We really have an all-star board. Last year, the PCDI launched a survey for patients with MBC. And this year, we launched a companion survey for medical oncologists with experience treating patients with MBC. And all of the questions on the survey went through our medical advisory board, who you just met. The objectives of both surveys were identical, but we wanted to hear them from both the patient voice and the oncologist voice. First objective was to understand the prevalence and severity of patients' treatment-related side effects. The second was to ascertain the level of physician-patient communication about side effects. The third was to increase understanding of the impact of lower doses on patients' outcomes regarding quality of life. And finally, to determine patients' and oncologists' willingness to discuss flexible drug dosing options together based on the patient's unique personal attributes, which you just saw. Their responses are enabling us to advocate for future improvements regarding side effect mitigation. I'm going to share in this slide and the next those survey results. The patient survey results are in white font, and the oncologist survey results are in tan. We received 1,221 patient responses and 119 oncologist responses to their respective surveys. 86% of the patients who participated indicated that they experienced at least one bad treatment-related side effect. That's an enormous majority. Interestingly, more than half of the oncologists estimated that 60% or less of their patients reported a bad side effect. So we could see that oncologists underestimated the prevalence of treatment-related side effects. 20% of the patients who had side effects had to visit the ER or hospital. The oncologist's estimate was close at 15%. More than 2 of 5 of the patients had to miss at least one treatment, and the oncologist's estimate again was close at 37%. The good news is that 98%, almost all of the patients who had side effects, said that they told their doctor about them. And in turn, 82% received assistance from their doctors. Of the patients who received assistance, 2/3 indicated that they were given a dose reduction to help with their side effects. 83% of the patients whose dose was reduced felt better, at least initially. That's really good news. And 74% of oncologists indicated that this was the case with their patients. The majority of the remainder said that patients' outcomes had varied too broadly to generalize. 77% of patients said that their doctor inquired about side effects at each and every visit, whereas 100% of the oncologists reported that they do this. So there's a discrepancy there. Getting back to our cancer drug dose paradigm, is a higher dose always better than a lower dose in terms of efficacy? A little over half, 53%, said no, they do not believe that a higher dose is always more effective. Interestingly, 85% of oncologists do not believe a higher cancer drug dose is always more effective. So that was really interesting to us. The fabulous news on both of these surveys was that the vast majority of patients, 92%, and oncologists at 97%, are willing to collaboratively discuss allowed MBC drug dosing options with each other based upon the patient's unique characteristics. So we're very encouraged. I've given you a lot of information. What can patients do? Well, first, when beginning a new treatment, discuss the patient-centered dosing criteria. And even if the drug in question only comes in one dose, it could still be helpful in deciding on your next treatment. Make your doctor aware of your personal wishes and priorities throughout your treatment because these change. If you are experiencing treatment-related side effects, talk to your doctor about how to relieve them. Options include reducing the dose, changing the frequency, trying a different manufacturer of the drug, because sometimes the filler that's put into a drug can cause the side effects, and switching to a different manufacturer may make things better. You might be prescribed medication for relief. You may even switch your treatment or be referred to a specialist. Make a collaborative decision with your doctor about how to reduce your side effect, but never, ever reduce your dose or alter anything about your treatment independently. Always speak with your doctor. What are we going to do now that we have data about patients and side effects, and we have it from the patient's perspective and the oncologist's perspective? What is next for the PCDI? We want to share these results with the FDA and hopefully hold a workshop. The time is perfect. And the reason I say this is right after ASCO last month, Dr. Rick Pazdur, the director of the FDA's Oncology Center for Excellence, stated that the primary objective of phase 1 clinical trials should be to determine a range of doses to be studied in phase 2 and other trials, rather than just identifying the MTD, as we saw earlier. That's music to our ears. We also want to engage pharmaceutical companies regarding dosage level efficacy because we need more data. We want to do this retroactively with regard to completed clinical trials so that outcomes of patients who are given lower doses in clinical trials due to adverse events can be compared in terms of efficacy and quality of life with outcomes of patients who stayed on the MTD. We also want to build that proactively into future clinical trial design. We've talked about the PCDI's approach and the FDA's updated approach. How do they work together? Well, there's the front-end aspect whereby dosage is identified in clinical trials. And then there's the back-end situation when the drug's been approved and we're sitting in front of our doctor in the clinic. Even after the optimal dose is identified in the clinical trial setting, with regard to the FDA's updated position, there will still be patients in the real world who tolerate drugs differently from patients in clinical trials, and we've talked about that before. There is room for getting it right at both ends, which is very important. What does success look like from the PCDI's perspective? Patients' dosages will be based upon collaborative physician-patient assessment of the patient's unique attributes and circumstances. Their quality of life may improve, and God willing, they may potentially remain on a working treatment longer due to lower toxicities. If you're interested in further reading, here's a list of really good articles on this. And I want to say thank you for your attention. If you'd like more information, please visit therightdose.org or email info@therightdose.org. And now it's my pleasure to hand this over to Dr. Aditya Bardia.
Thank you so much, Anne. That was terrific. Thank you for leading this initiative, and I've seen the progress over the past 2 years, and it's just amazing. And I'm very privileged and excited to be part of this initiative, the patient-centered dosing. So over the next 10 minutes or so, I'll build on what Anne mentioned and share my perspective related to patient-centered dosing and why it is so important. So I'm a medical oncologist, breast medical oncologist. I predominantly take care of patients with breast cancer. I have a large practice of patients with advanced disease, metastatic disease. I run clinical trials. So I wanted to start with a patient story. A 65-year-old female who had a diagnosis of hormone receptor positive breast cancer. This was in the year 2000. She received 5 years of adjuvant tamoxifen, which was the standard of care at that time. Now it's 10 years. And then unfortunately, 15 years later, had disease recurrence, something that we do see with hormone receptor positive breast cancer. Then received letrozole plus CDK4/6 inhibitor, which is the first line recommended treatment for hormone receptor positive metastatic breast cancer. And then after about 2.5 years, had evidence of disease progression. The question was, what therapy should be considered next for this patient? So the paradigm at this time in the era of precision medicine is that of molecular profiling. Based on clinical information plus molecular profiling, the combination of these things can help us select precision therapy. The question is, in the era of precision medicine, is determining the maximum tolerated dose the optimal strategy for dose determination in a clinical trial? Often, access to precision therapy is through a clinical trial. If you take a step back and building on what Anne was saying, the traditional model of drug development in oncology has been that more is better. And this comes from chemotherapy. This is a graph which looks at dose and the probability of toxicity or efficacy. The y-axis is probability of toxicity efficacy, the x-axis is the dose. So as you increase the dose, the probability of toxicity or efficacy increases. And this 3+3 design comes from this model. At a certain point, which is highlighted here in the graph, the probability of efficacy is 30% and the probability of toxicity is 10%. So at this specific dose, which is X, the probability of efficacy is 30%, toxicity 10%. So if you divide 30% by 10%, that is 1/3. And that essentially is the idea of the 3+3 model, that we would have this ratio of 30% probability of efficacy and 10% probability of toxicity. And then as you further increase the dose, you might have more efficacy, but you're likely going to have more toxicity as well. And that's why at some point it stopped, and that's how the term of maximum tolerated dose was developed. The challenge is that this might be a good concept in the era of chemotherapy, but it's not a good concept in the era of precision medicine. There was a study presented at ASCO a couple of years ago, which looked at phase 1 trials of targeted therapies or precision medicine therapies. Only 59%, actually 59% of the studies did not have maximum tolerated dose reached, because often with targeted therapies, you can increase the dose, but you don't see much toxicity and maximum tolerated dose is not reached. And the concept in the era of precision medicine is less about maximum tolerated dose, but more about OBD, or optimal biological dose. Many times, however, optimal biological dose is not reported in clinical trials. In the same study, the authors found that 40% of studies did not even report on the optimal biological dose in a phase 1 trial. Now, what is optimal biological dose? Optimal biological dose is defined as a dose that reliably inhibits a drug target and allows a target plasma concentration of the study drug. What it requires is two things. First is understanding the relationship between magnitude of target inhibition, ideally in the tumor, and disease inhibition. So the correlation of if you are able to inhibit a target in the tumor cell by X percentage, this is the amount of disease inhibition or response that you're going to see. So that relationship is really important in defining optimal biological dose. And the second is the amount of free drug that's available, accounting for variation in drug metabolism and absorption. Now, if you talk about examples of drug development, Anne had reviewed abemaciclib, but just to make the point again, in the development of abemaciclib, initially the recommended dose was 200 milligram twice daily. And the phase 3 trial, which led to approval of abemaciclib, actually started with 200 milligrams twice daily. But during the study, after review of safety data and dose reduction rates, the protocol was amended and patients were allowed to start at 150 milligrams twice daily. So this just highlights how you even have phase 3 trials that don't have the perfect dose and require adjustments. And in part, this was based on what was seen with pharmacodynamic inhibition, a beautiful study looking at pre-treatment biopsies and then on-treatment biopsies, which from a patient perspective, many a times is challenging, but from a scientific perspective provides a lot of valuable information, particularly with targeted therapies, because you can look at the amount of target inhibition. So in this study, the authors found that the amount of target inhibition with 150 milligrams twice a day of abema versus 200 milligrams twice a day of abema is the same. There's no major difference as far as the target inhibition is concerned with a higher dose, but if you increase the dose, there's more toxicity. So the authors said that 150 milligram twice daily is a good dose with abemaciclib because you can have good target inhibition and the toxicity is lower. And in the phase 3 trial, that's the dose that was subsequently developed, and the approval of abemaciclib in combination with endocrine therapy is at 150 milligrams twice daily. So just highlights how good understanding, good science with pharmacodynamic evaluation can help us select the best dose, the dose that would cause maximum target inhibition. Now, I would highlight it's just not about high dose, because sometimes lower dose might not always be better. And a good example of this is fulvestrant, where a trial that looked at 2 different doses of fulvestrant, 500 milligram versus 250 milligram, demonstrated that by increasing the dose to 500, you have better outcomes. There was an improvement in progression-free survival with 500 milligram as opposed to 250 milligram. So it's less about high versus low dose, it's more about the optimal dose. Now, one thing to understand is that the optimal biological dose is about biology. It's about target inhibition. It does not necessarily guarantee efficacy. And a quick example that I want to provide is that of ER-positive breast cancer. If you think of a tumor cell that has the estrogen receptor, estrogen binds to it and causes estrogen-mediated signaling. But what can happen over time is that the tumor can become ER independent and it can start signaling through other pathways like EGFR and IGFR. And that can result in tumor growth. So you can imagine a scenario where a tumor which is ER independent, but dependent on these alternate growth factor pathways, if in such a scenario you use a drug that blocks the ER pathway, it could block the ER pathway completely, but that does not guarantee that it would control the disease, because in this case, the ER pathway is not relevant. So an endocrine therapy with 100% ER pathway inhibition would have limited impact on a tumor that is ER pathway independent. if the target in a cancer cell is not relevant, you can have the best targeted therapy. It's not going to have an impact as far as disease control is concerned because the target is not relevant. So in conclusion, in the era of precision medicine, optimal biological dose is a much better endpoint than maximum tolerated dose, but is often not reported clearly in clinical trials or scientific publication of the primary results. And various caveats need to be considered in interpreting optimal biological dose. Many times the degree of target suppression required for optimal clinical efficacy is not clear. Optimal biological dose indicates inhibition of target, but disease progression on a study agent does not mean suboptimal biological dose. It could be that the target is not relevant in that setting. So we need to carefully consider patient population relevancy of the target and target heterogeneity. So coming back to this model again, we were talking about precision therapy. I think a key component with precision therapy is optimal biological dose. And coming back to this patient, I discussed when the patient had disease progression, letrozole plus CDK4/6 inhibitor, I discussed various options, clinical trial, standard of care therapy. The patient decided to start standard of care therapy with an FDA-approved agent. However, that provided a learning lesson. The patient had significant toxicity with using the standard of care medication. And this was around the time that I got in touch with Anne and was acquainted with this idea of patient-centered dosing. And it was almost like an aha moment because it made me think about that we need to move beyond optimal biological dose to patient-centered dosing. The first step was to move from maximum tolerated dose to optimal biological dose. But even optimal biological dose is about the disease. But rather than being disease-focused, we need to be patient-centered. It's much more than the disease. And that's why this concept of patient-centered dosing is so attractive, because it moves beyond the disease. The idea is that we move from right targeted therapy for the right tumor to right therapy for the right patient at the right time with the right dose. Obviously, it's complex. We need to consider various factors, the goals of treatment, prior tolerability, access to therapy, overlapping toxicity, cost, resources. But that's why medicine is complex. It's not one size fits all. That was the whole idea with precision medicine. The tagline was one size does not fit all. And it's the same with dosing as well. You have to consider various factors, and by assessing the various factors, particularly the patient consideration, choose the right therapy for the right patient at the right time with the right dose. Thank you so much for your attention.
Thank you both for a really great presentation. I want to invite the audience to submit some questions through the Q&A pane. Some questions have already come in, and some questions were submitted even before the webinar began. But maybe, Dr. Bardia, we can start with you. Someone asked, can you please explain what precision therapy is?
The idea with precision therapy is to choose therapy based on molecular characteristics of the cancer. And a good example of precision therapy is the FDA approval of alpelisib or Piqray for PIK3CA mutant hormone receptor positive breast cancer. So we know that breast cancer is not one disease, even hormone receptor positive breast cancer is not one disease. A subset of hormone receptor positive breast cancers have a molecular alteration in a gene called PIK3CA. And when there's a molecular alteration in the gene PIK3CA, that switch is constantly on, and the tumor is massively driven by that pathway. So if you use a drug that inhibits that pathway, it in the pivotal phase 3 clinical trial demonstrated evidence of clinical efficacy. So it's an example of where a drug like alpelisib got approved for a subset of molecularly defined hormone receptor positive breast cancer, that is PIK3CA mutant breast cancer, and that's example of precision therapy. In the pivotal trial, they also looked at patients who do not have the PIK3CA mutation or PIK3CA wild type, and in that setting, Piqray did not have any efficacy. So the idea is of a selective targeted therapy based on certain molecular characteristics of the cancer, and that's precision therapy.
So someone is asking, what is the overall goal? Is it so that each patient would have patient-centered dosing? Is that the overall goal of the initiative, Anne?
Yeah, I think in a nutshell, the idea is that every patient and every oncologist, when that patient starts a new treatment, would discuss the patient's unique attributes and circumstances, as we've seen, and then jointly decide on the treatment that seems right given the circumstances at the time, although that's not our main focus. But if that drug comes in more than one dose, decide on the dose that's best for them at the time. So they may, be dealing with a series of stressful circumstances and comorbidities, and maybe the RSD is not the best for them at that point. So it's to have that dialogue and jointly make a decision. In many cases, the recommended starting dose or the maximum tolerated dose may be the one they both decide on, but they'll have had that dialogue. And I believe, having had that dialogue, the patient will go away with a better feeling about their decision than if the doctor just told them, okay, this is what you're taking and this is your dose.
So when patients leave today's webinar, what is the main takeaway you would like them to have as a result of listening to you and Dr. Bardia today?
I'll take that first. I would love everyone to have a copy of this list and a copy of these key survey results readily available. Take time, look them over, think about them. And then to talk with their friends about it, talk with their doctors about it, and see how it feels to actually begin actioning this. That would be the takeaway. Talk to your friends, talk to your family, talk to your doctor about this, because it's a new paradigm. This isn't the way medicine's been done for for decades. But start dipping your toe in the water and start talking with your doctor about this. And on our website, we have studies of at least 6 drugs where we have efficacy information about the lower doses. So I really encourage patients to take a look, talk with their doctors, talk with their families, talk with our friends, and start formulating their own ideas of how to go forward.
So someone is asking if there's a better adjusted dose, can that potentially protect our bodies from harmful side effects? And could that increase overall survival?
I can take this one on, absolutely. I think the idea is the right dose for an individual. If patients are not able to take drugs, you cannot derive benefit from the drug. You cannot derive benefit from a drug that you cannot take. And for some patients, it could be a certain dose. For others, it could be a different dose. But anything we do, our goal is twofold in the metastatic breast cancer setting. The first is to prolong survival, and the second is to maintain improved quality of life. So anything we do, including the use of a specific dose, needs to be aligned with these two goals.
So someone is asking, how do you know when to reduce the dosage?
Usually, I'll let Dr. Bardia, but from what I've seen, I got involved in this by looking at social media for years, as a patient. And I saw so many people suffer, not just from the disease, which we expect, but from the treatment, which I didn't expect to that extent. And, it's been the routine to start the patient on the highest dose and then dose reduce when they have a side effect. And that's done today. We see it done routinely. When is the right time to dose reduce? Well, a dose reduction implies that you started on the highest dose initially. So after a side effect or something, I would expect the dose to be reduced. But again, now we're talking about a paradigm change of talking about the right starting dose, for that patient as well, based on their attributes. Dr. Bardia, do you have some more to add to that?
I agree. The current paradigm is that if a patient has toxicity, that's when the dose would be reduced. And the dose reduction is based on the FDA label. FDA label has guidance. You start at this dose. If you're having grade 2 or grade 3 toxicity, you reduce to this level. So there's clear guidance. In terms of how to start with a lower dose, at this time, we don't have clear guidance from the FDA or other institutions. And that's why it's a paradigm change. And I think we need to have additional conversations. The vision would be that in the future, even the package insert has that you can start at this dose or this dose, and then also have corresponding information that for certain patients with X, Y, and Z, maybe a lower dose would be better to start with. And then once you start, in the future, you can always adjust. The challenge is to start at a lower dose, and we don't have clear guidance in terms of how to do that.
So there are a couple, Anne, go ahead. Did you want to say something?
Yeah, I do have something to say. I had mentioned that we wanted to hold a workshop with the FDA. We wanted to share the results of these surveys with them and this information. And as Dr. Bardia mentioned, the ideal would be to have a range of starting doses with a caveat that an appendix in the package insert would say, these are the patient-centered dosing criteria. Decide on one of these doses within this range based on that criteria, and also whatever efficacy data we may be able to put in the package insert, because that's one of the things we're going after pharma for. So the idea would be to update the package insert, to have a range of potential starting doses, to take the criteria into account, and ideally the efficacy if it's available, making the decision.
And did you say earlier that not all medications have different dosing levels? Some do.
Right, and some don't. Like typically endocrine therapies do not. I think tamoxifen might be an exception, but typically endocrine therapies come in one dose and one dose only. So for those, we're not going to have dosage level discussions, but the patient-centered criteria when deciding on what particular endocrine therapy to take, the patient-centered dosing criteria could be relevant for making that decision. And I'm going to just use an example right now, and this is right up Dr. Bardia's alley because he's working on an oral SERD, which could potentially replace Faslodex. I mean, as a skinny person, I'm really worried about potentially having Faslodex injections. So one of my personal goals and wishes may be to avoid them if at all possible. So if there's an oral SERD, available after an FDA approval, God willing soon, I would want to talk with my doctor about the pros and cons of taking that if it was approved versus Faslodex, because my personal goal and wish would be to avoid a shot, 2 shots.
So there are a couple of comments and sort of questions about gender. And someone is saying no one knows the effects of the usual treatment better, usual treatment being used better than our men with breast cancer. That, most of the drugs are tested on women, that men or, gender can have a major impact on the efficacy or the level of side effects. Any thoughts about that?
Yeah, absolutely. And I think the challenge is we don't have much data. And if you just go by the label, it's just starting everyone at a standard dose. Clinically, we've seen differences. An example that comes to my mind is a drug called cabozantinib, which was initially being developed in prostate cancer and was being used at a certain dose. And at our institution, we then opened the trial in breast cancer and we started with the same dose. Oh boy, that was just way too toxic. And then we had to change the dose and come up with additional criteria. And the trial was initially designed as that it was not a dose escalation trial, but then we had to change the trial design. So absolutely, gender could have an impact for certain drugs. BMI could have an impact. The level of organ function could have an impact. And that's the idea with patient-centered dosing, that we look at certain criteria and then try to come up with the best guesstimate that this is the best dose or the right dose for this patient. And then you start with that dose upfront rather than waiting for a toxicity to happen and then adjust.
So there are a couple of questions about drugs being reused in the course of treatment. So like if you used a chemotherapy agent at one point and maybe looking at the possibility of using it again at a lower or higher dose, is that something that you're looking at as well? Or any thoughts about reusing drugs at different doses?
Yeah, from a scientific perspective, is something that I guess one could consider. The challenge is you necessarily don't know whether a higher dose is necessarily going to work. So if someone is on, say, tamoxifen at 10 milligram, if I use 20 milligrams, would that be better? Or someone is on tamoxifen at 20, would I use 40 milligrams? Would that be better? You don't know. And then by using a higher dose of a drug that's not going to be effective, you're just wasting time as far as efficacy is concerned. But you do know that with a higher dose, there'll be more toxicity. So the worst scenario would be you increase the dose and give the drug. Patient has a lot of side effects, and then 2 months into the treatment, you do scans again just to find out that it was ineffective. I think a better strategy would be development of newer drugs that target different pathways, because we know that under selective pressure from therapies, usually tumors can activate other pathways or develop new mutations. So if we understand how the tumor has evolved, using a drug that targets that evolution probably would be more effective.
So there's a question here about the oral SERD. Is it being tested on a population that will actually be taking the drug, such as men, Blacks, and people other than white people?
Yeah, in the pivotal clinical trials, phase 2, phase 3 clinical trials, the trials do allow men, do allow women of all colors, so there's no restriction per se. But once we get the data, then we'll be able to see the percentage of patients who were either males or Black women. So once we have the data, then we'll know. If it looks like it's underrepresented, then one idea would be to pool different studies so you have enough power to look at that population, or from a regulatory perspective, require that real world data gets generated so you know about efficacy in these specific groups. For example, for palbociclib, the pivotal trials did not have a number of males who were included, but through flat iron and real world data, the team was able to gather information about efficacy of palbociclib in men. And actually, based on real world data, FDA modified the label to include males with metastatic breast cancer. So it's just not clinical trials that influence label. Sometimes from real world data, we can also get valuable information.
So I think we have time for maybe one more question. What testing would need to be done on an individual to evaluate whether they can safely receive a lower starting dose to maintain efficacy in a drug that does not provide, different dosing levels?
Yeah, I can provide my comments and would love to hear from Anne as well, because she developed the guidelines in terms of the various criteria. From a testing perspective, I think the key would be organ function, to look at the white blood cells, the hemoglobin, the platelets, the renal function, and the liver function. So that would provide a general idea about metabolism that's related to that drug. And if a patient has organ dysfunction and the drug is metabolized through that organ, it could result in more toxicities. So looking at a lower dose probably would be better for that individual.
And I just thank you, Dr. Bardia. And I just want to be very clear, for a drug that has no possibility of dose reduction, such as most endocrine therapies, we're not advocating to reduce the dose or take it every other day if it's supposed to be taken daily. We're absolutely not advocating for that. It's only in the cases where there are potentially allowed lower doses. And we're saying, talk about what dose is right for you. We didn't mention, and I'd like to bring that up, is there are some cases where patients are not automatically started on the highest dose in today's world. As Dr. Bardia alluded to a bit, there are medical contraindications such as renal or hepatic, kidney or liver functions that could preclude a patient from being given that high starting dose to begin with. The best thing to do, I don't know if there are any pre-tests to say, okay, it's a lower dose is best for you if the drug comes in multiple doses. But like anything else, we could continue taking our lab tests and our scans to see how well or not well that drug is working. And one thing also, if a patient opts to decide on a lower dose with their doctor and eventually wants, for whatever reason, to titrate up to the higher dose, there's nothing stopping them. It happens in today's world too, as long as they're able to tolerate it and they want to, and the doctor feels it's the good thing for them. There is one, I'll just digress for 1 second. I know we're a little out of time, but recently the drug neratinib had the package insert changed to start at a lower dose and titrate up, because so many patients who are taking the RSD were experiencing terrible diarrhea. So now they're given certain weight on the lower dose, then it goes up a dose, and then it goes up one more dose and they stay on it. So this is all beginning to change as we speak in the real world.
Thank you, Anne. So Dr. Bardia, someone is asking for your contact information, if you'd like to share it. If not, that's okay too. And
No, absolutely. By all means, my contact information is also on the web page. You can call my office or my email, which is abardia1@partners.org. Feel free to reach out to me. Happy to help.
So thank you both for a great program, and thank you to everyone for participating today and submitting your questions. If you wouldn't mind just taking a moment to fill out the survey at the end of the webinar, we'd really appreciate it. The survey will show up when the webinar ends, and all of the responses will be kept anonymous. Thank you, Anne. It was so good to see you, Dr. Bardia.
Thank you, everyone. Pleasure.
Thanks so much.
Thank you.
Thanks,
Thank you.
everyone.